I'll try to keep an eye on the time. Sean's going to go around with the mic. So we'll go ahead and get started. Want to welcome all here to the ESC in Amsterdam. We're here at the World Heart Federation Café for a very important panel discussion. And this panel discussion includes global experts on CKD and cardiovascular health, a very important topic that we're not only recognizing more about, but recognizing the possibilities of early identification and early opportunities for prevention. My name is Dr. Lawrence Sperling. I'm a professor at Emory University School of Medicine, a professor also in our School of Public Health and Global Health. And I've really had the privilege to work with the World Heart Federation, I think for over a decade, maybe 15 years. And what I'd like to do, first of all, is just introduce the topic. I want to thank our supporters from AstraZeneca for allowing us to be here today at the Heart Cafe at ESC in Amsterdam. And as many of you know, this topic, the intersection between CKD and cardiovascular health, we're more and more recognizing the importance of this for those that trust us with their care and their health. This remains multifaceted. Although it's challenging, we have many tools to address this. The connection between the two is really crucial for effective care management, and it's also, we're learning the commonalities that CKD is a progressive decline in kidney function, and related cardiovascular complications include a very broad spectrum of disease states that include heart failure, coronary artery disease, and hypertension, but really all vascular disease from head to toe. They're early warning signs, and these conditions, they share common risk factors, but they also share common pathophysiological mechanisms contributing to what is a bidirectional relationship that amplifies the impact on patient health. I'm a preventive cardiologist, so as we think about the amplification of disease states, we should also think about the amplification of preventive possibilities. So I'm going to start across our panelists here, going left to right, ask our panelists to introduce themselves, and then we'll get off to a enjoyable conversation. Probably have about 35, 40 minutes for our panelists to discuss from their expert positions, but then we'll leave some time for our audience for questions, comments, dialogue. Our panelists will give some final comments, and I'll wrap up the session, and that's what we'll do for the next hour. So we'll start off here, and please introduce yourself and why you're here with us today.
Thank you. So I am, I'm Helen Ye. I work with AstraZeneca. I lead the global CVRM medical team at AstraZeneca, cardiovascular, renal, and metabolism. I'm thrilled to be here, and I love that we're talking about CKD in a heart cafe at the ESC. I think that's a huge step forward, and I'm very happy to see it happen.
Thanks, Valerie. And
I'm Helen.
I'm sorry. Thanks, Helen. All right, I'll get everybody straight, but all right, thank you, Helen.
Right.
So.
Thank you. My name is Prabhakaran Dorairaj. I'm a cardiologist and an epidemiologist from India. I'm currently Director, Center for Chronic Disease Control and a member of the WHF board. Why is a cardiologist here in a kidney program? It's because of the bidirectional relationship between heart disease and kidney disease, and both are precursors of each other. And I think prevention is common to both. So that's the reason why I'm here.
Wonderful. All right, so we'll move on to our panelist, who is really the most important member of our panel.
Oh, thank you very much. Thank you very much. Stephen McCarry, Scottish, but from France, representing heart failure patients. I myself am a heart failure patient and involved in a lot of work with AstraZeneca and numerous others, not to mention them all.
Tell us a little more about yourself. I know we all all will someday be patients, but we're all people. So tell us about you as a person.
That's an interesting point because there are certain associations in France who have dropped the word patient and talk about citizens.
Yes.
Because that only kind of exaggerates the divide between
Sure.
the knowledgeable and supposedly non-knowledgeable.
Yeah, people living with, because we are all people.
Yeah, all of the documented works that we've published, we talk about people living with and not people suffering for, or people, I can't remember in English how you say, atteint de. But it's important. I do a lot of advocacy work for policy changes within Europe, particularly with Heart Failure Policy Network, who have just launched a campaign in Europe, who are, they're improving the campaign within Europe, but also at the moment we've got a call for action to deal with mental health problems for cardiovascular and kidney disease patients, because it's one subject that's overlooked, and an important one. So it's not just the clinical care that's important, it's the holistic attitude. That's why we say citizen and not patient.
Wonderful. And Valerie, I am trainable, so I think I'm getting everybody down here. So
thank you very much. So I'm also feeling extremely excited and very privileged to be here. I'm representing the International Society of Nephrology. I'm the chair of the advocacy working group, and the International Society of Nephrology is really advocating for kidney health for everybody everywhere, very interested in quality of life, quality of care, and an enormous part of the care of patients with kidney disease is looking after their hearts. So again, I think a perfect fit, and very excited to participate today. Thank you very much for inviting us.
Great. And we'll probably take a question at a time for each of our panelists, but feel free. This should be a natural dialogue, and a conversation. So, feel free as panelists to add to what our experts have to share or ask a question yourselves. So maybe we'll start off with Valerie. So you have significant clinical experience in nephrology and preventing the progression of CKD. Can you highlight some of the key aspects of this relationship, the bidirectional relationship we've mentioned, and what can we as clinicians how do we think about this, keeping it in the front of our mind and breaking down the silos, understanding that these are not separate, these go together?
Thank you. Yes, so I think one of our slogans, and this was actually the slogan of one of the World Kidney Day campaigns a couple of years ago, to protect the kidneys, you should protect the heart. And in the kidney patients, you need to protect the heart, because most patients with kidney disease actually die of cardiovascular disease. And interestingly, the younger the patients are, for example, young people on dialysis have about a 500 times increased risk of dying of cardiovascular disease compared to young people the same age without cardiovascular disease. So part of our message is really that we're not exactly breaking down the silos, not just stomping our feet and saying people need to be aware of kidney disease, but again, looking at the entire patient and really realizing that cardiovascular disease is a major morbidity for patients with kidney disease, but also kidney disease is an enormous risk factor for cardiovascular disease. We were very happy to see that the latest ESC guidelines have actually included proper screening for kidney disease, which means blood tests for serum creatinine or cystatin C and looking at protein in the urine. And a patient who has those is considered very high risk according to the guidelines. So one of our concerns is that awareness of the guidelines is low. We do know that drugs work. We've had randomized control trials. We know that all the latest drugs actually save hearts, save lives, and save kidneys. But the uptake of these medicines is very low. We know it takes about 17 years to get evidence into practice for both cardiologists and nephrologists. And so I think really one of the strengths, the synergies, is if we all work together, we can shorten those 17 years and really start to save lives now. Because what we know, for example, with patients with kidney disease, we can prevent them from dying of heart disease, but we also want to prevent the kidney from getting worse and them needing to get to dialysis or transplant. So the latest latest medications, the SGLT2 inhibitors with the ACE inhibitors, really can prolong that time that people can live quality lives without dialysis and transplant and without having intervening cardiovascular events. So I think we need to really emphasize together that guidelines work, and then we need to advocate with the primary care physicians in other settings, lower and middle income settings, with task shifting, task strengthening of other cadres of health workers to help with screening, early diagnosis, and then engage with the citizens, the patients, their families, to really also think we can't only treat, but we also want to prevent, and that really means lifestyle, that means public health interventions, and there we need to engage with the policymakers as well.
Yeah, thanks. So we must do better than 17 years for a high-level adoption of guidelines. We really are at an incredible time to be able to not just raise awareness of this intersection, but intervene. And so it's all about taking that knowledge into practice. I often describe the delivery of healthcare as episodic, fragmented, and often catastrophic. And so we would like to hear from our person on the panel living with CKD and cardiovascular disease, Stephen. And so, Stephen, you live with several conditions and have spoken about the challenges navigating a health system that can seem quite disjointed. Can you tell us more about the challenges and how we can listen better and help you and others not only improve quality of life, but we have tools to reduce rehospitalization and extend a healthy life?
Okay, that's kind of a multifaceted question and a big one. First of all, relating back, I mean, a lot of heart failure patients eventually develop kidney problems. One of the things that I've noticed now, I'm not your typical everyday patient. I'm somebody who's looking and learning. So I'm aware of the fact that it could be an end stage for my heart failure. But I don't think, in general, we alert patients or tell them even why they're having creatinine every 3 months. So they don't know what the risk is. Is it because it's a fear of frightening them or whatever? I mean, this is one big thing that we've been talking about in heart failure for quite a while. It is a serious illness if not treated and managed. But we announce it as if it's just, oh, your heart's tired. We don't really give the full impact of the disease. I mean, we do when we're talking about cancer, but we don't with heart failure. It's like, why? You know, the patient has a right to know about that. So the other thing which you said was navigating between, and one word that sticks in my mind that we use everywhere in every situation is silos, silos, silos. You know, my cardiologist deals with the cardiology part, my rhythmologist, an electrophysiologist in France, in the UK and America, he deals with that. I have another cardiologist who deals with the heart failure part. I then have sleep apnea, so I've got somebody else who deals with that, pneumologist. And then I have diabetes. And the diabetes, funnily enough, is the only one that kind of interacts because of the SGLT2, because it has an impact both on the diabetes and the heart failure.
And the kidney.
And the kidney, yeah. I only learned that recently from studying. But the connection between all of them is fairly disjointed, you know. There is no one person who coordinates. Perhaps, I don't know much about it, but I've heard, for example, in Quebec and in the States, you have what do they call them?
Navigators.
Patient navigators. Is that not, could that not be used as some way of getting the multidisciplinary team to work together?
I think that's an important idea that is being implemented now in various scenarios. And it's important to be your own advocate and be educated coming to these visits with questions and yourself trying to coordinate care. You know, at our university, we we often refer to the term heart failure because that term in and of itself can be very scary. But instead of having a heart failure program or heart failure clinic, we call it a heart success program. So we can turn heart failure into heart success. Doesn't that sound much better? And we frequently, either subliminally, hopefully unintentionally, talk about patient non-adherence or non-compliance. But as you mentioned, the flip side of that is therapeutic inertia. So even when we do know the guidelines and the evidence and the compelling evidence, we often don't move forward with that, thinking somebody else on the care team, these silos, well, the endocrinologist should be the one to start that medicine, or the nephrologist, or the cardiologist, or the primary care doctor. Ultimately, nobody does, and time goes by, and that time is very precious. So, Helen, you've spoken about the challenge of improving CKD awareness and the problem of underdiagnosis related to this. How do we improve upon this? How do we become more aware, and we broadly, and why is it important to take a health system approach? Because as we think about these silos and ask more and more of our clinicians with less and less time, I think we need to take systems approaches.
Yeah, thank you for the question. And I think we've started to touch on some of the key themes already, and you said it in your question. It's all about we in my mind. It's how we work together. And I think when I think about the importance of connection, it's the connectedness across the different disease states. So the fact that we're considering the heart and the kidney together here is hugely important. But it's also the connectedness across the care pathway. So it's, physicians, patients, pharmacists, nurses, policymakers, industry partners, diagnostic companies. We all have to be working together, because I think it's clear that we have a common goal here, and the common goal is the patient and improved outcomes. So I think it starts with initiatives like this, by having the conversation, by working together. And I think awareness itself is huge, right? I heard Stephen mention cancer before, but the prevalence of CKD, what is it? Over 800 million people globally are living with CKD. If that was cancer, it would be all over every newspaper every day. Why is it not more prominent in terms of the huge prevalence and the burden of disease? That never ceases to amaze me. So I think we start by talking about the problem, by raising the awareness, and then I think we have to quickly then get to, well, how can a patient get a diagnosis, and what is the importance of a diagnosis? Because if you can get a diagnosis, and it shouldn't be too difficult, it's a blood test, it's a urine test, it shouldn't be too difficult. And if you can get a diagnosis, then there are medications available that can slow your progression, can ease, the path to end-stage kidney disease. So there's a lot that can be said about the positivity of raising awareness and getting a diagnosis.
So the we is really important. The team.
Yeah.
And we frequently talk about patient-centered care, but it should either be people-centered care, or even better, I frequently talk about people-partnered care, because, it's nice to talk about the center, but this is a partnership. And when I start off with a patient, I say, this is a partnership. And you always get more votes than me, by the way. I'm here to guide you. I'm here to listen. I'm here to help. But I'm never here to convince. But I'm here to provide expertise and guidance. But together we'll find the right path. And I think that's really important. So, Prabha, you go by Prabha.
Prabhakar, yeah.
Prabha, I'm sorry. By Prabha. You've done a lot of things at a leadership level for the World Heart Federation, for the country of India, in NCDs related to the epidemic specific in India. But tell us a little bit about the CKD prevalence, burden, and care in your country, but also give us a global perspective.
Right. When we look at the numbers, it's quite staggering. Are you able to hear me? Okay. In India, If we include, it depends on how you diagnose kidney disease. If you are including, stage 1 disease, we have around 140 million people with CKD. That's the number. If you're looking at advanced kidney disease, people who require advanced treatment, including dialysis, it's around 18 million people. Huge numbers. In terms of prevalence, adult prevalence above the age of 30 years is close to 12%. But the big problem is awareness. Awareness is extremely poor, particularly for kidney disease. I mean, awareness is much better for diabetes, for hypertension, for heart disease, but for kidney disease, it's quite poor. And appropriate therapies, even amongst doctors, is less than 10%. So the guideline-based treatment is less than 10%. So you might ask me the question as to why are people not accepting guidelines? I think it's the narrative. When we talk about guidelines, we are focused on evidence-based therapies. We know that you have to get it from the evidence that is available. But we are poor on how to actually scale it up and make it sustainable in terms of implementation. And I think that's where we fail, because any intervention that is required has to have a specific context. It has to be sensitive to the cultural context. It has to be equity promoting. It has to be cost effective. So there are a lot of elements there. But most importantly, I think you also pointed out that primary care is the best place to start prevention. And for that, we need to engage with patients. And that's not happening anywhere in the world virtually. I mean, today we have a person here, and thank you for coming. But in most situations, I've seen in many places, even in our Indian conferences, we don't even talk to patients. So I think co-creation of interventions for prevention with patients, community engagement, and actually looking at some of the new ways of engaging the health system. Like when we look at introducing a new product in the market, the companies do a lot of things. They do discrete choice experiments. We don't do it. We don't go and ask patients, what would you think is the most important thing? Would you be happy with a nurse examining you or a community health worker examining you? What would you trade off in terms of time? Those are the kind of things we should think out of the box in terms of innovating.
Really important points. And, we talk about guidelines and evidence. We often speak from eminence, but we really need to speak from the heart. And we need to learn to listen better. And your point about the primary care clinicians, Stephen said, hey, we need coordination of care. And everybody said we need to break down silos. But it's frequently about safety and trust. I wrote a piece for Jack, commentary, 10 years ago. And it was titled Safety and Trust Beyond All Else. And that safety and trust has to be across health systems. We have to have trust in our guidelines, of course. And the people who are seeking care need to feel safe and have a trusted relationship, not just a medical relationship. Really important. So we'll come back to Valerie. And your research interests include resource allocation and equity. So in access to CKD management. And there's a difference between equality and equity. So first help us understand that. And then can a better understanding of the CKD's cardiovascular disease links and health systems adaptations lead us to more efficient uses of resources and improve access to care?
Thank you. So just very briefly, I think also to start with these 850 million people living with kidney disease have not been measured. Some of that's extrapolation. Even the data in the Global Burden of Disease study is extrapolated because people do not have access to a creatinine test. So that is a huge inequity, because in high income settings, very easy, sometimes done way too much. In low income settings, even people who desperately need it don't have access. So an inequity is something that's unequal, but that's unfair and should be remedied and can be remedied. Another important thing about kidney disease is the Global Burden of Disease, again, monitors mortality, But from India and from other low and middle income settings, we know that non-communicable diseases and kidney diseases are very common causes of premature mortality. Kidney disease specifically is not measured. There are probably between 2 and 7 million people who die without access to dialysis and transplant around the world, unmeasured, undocumented. And so this is again why prevention is key, because I think there is very difficult to ever dialyze those 18 million people in India under universal health coverage. Kidney disease is the leading cause of catastrophic health expenditure. That means people are becoming impoverished, trying to pay for their care out of their pockets. And this is not only dialysis and transplant, it is also just medication. In some countries, 5 medicines required to treat heart failure and kidney disease take 11 days of wages. This was a study from Malawi. So enormous inequities in access. And so from the International Society of Nephrology, we're really trying to push this equity that people need access to diagnosis. The other big thing I think we need to remind people, again, coming back to these silos, the treatment for kidney disease and cardiac disease, even diabetes, it's the same. So the policymakers and the clinicians don't need to think we need 3 different guidelines. We should integrate our guidelines, integrate our education. There have been studies showing that primary care physicians would need 27 hours a day to follow guideline prescribed therapy in all their patients. This is not realistic, so we need to simplify things, get down to the nuts and bolts. And from the ISN point of view, we're trying to work with the World Health Organization to really integrate kidney disease screening in appropriate patients, access to treatment, access to diagnosis for the right people, and then affordable access to treatment, because that's an enormous problem. The poly pill is something that could come out as being highly efficient. It works very well for cardiovascular disease. It decreases cardiac mortality in people with kidney disease. We don't yet have great data that it necessarily prevents kidney disease getting worse, but I think it's often started too late. So the message from the kidney side is, if we want to be efficient, we need to diagnose early. We have to suspect kidney disease in people, everyone at risk of cardiovascular disease, and then really start very, very early. And then we have the best chance of improving equity and giving everyone around the world a chance to live quality lives with kidney dysfunction.
Yeah.
I'd love to pick up on the policy point, Valerie. How do we do this from a policy perspective? Because your point about heart failure, CKD, diabetes, hypertension, all coexisting, is it one policy under chronic diseases, or is it how do we action that?
Well, would you like to answer, or shall I?
Yeah.
Can I just say very, very quickly? And the WHO is focused on initially the 4 major killers. It was non-communicable disease, cancer, diabetes, and stroke. Then added mental health. Kidney disease is not in there. I think one has to really think more NCDs, but I think you probably have more insight.
Yeah, I think in terms of policy, we need to make policy which is simple, which can cater to huge burden of disease. So taking the burden of disease approach, NCDs contribute to almost 2/3 of the deaths across the world. But the prevention of NCDs is very similar for all these diseases, be it cardiovascular disease, diabetes, kidney disease, lung disease, cancer, everything is similar. So it is said there was a website called 3450, 3 risk determinants leading to 4 disease causing 50% of the mortality worldwide. So you focus on these 3: tobacco control, hypertension, and diet. So these 3 can actually control the 4 diseases, which are lung disease, cardiovascular disease, cancer, and diabetes, and result in reduction. So at an upstream level, what can be done? At an upstream level, we call what are called as non-personal policy intervention, where people do not perceive the change. Like, for example, if you tell people to reduce salt, they find it very difficult because the taste changes. But take the example of UK. In UK, within 30 years, there was a 50% reduction in CVD. And one of the major reasons, of course, is tobacco control. But another important thing was, in 10 years, they reduced salt content in bread by 50%. All they did was, every year they reduced it by a small amount, where people did not perceive the change. So you require non-personal policy interventions where people don't perceive the change. And when we do those upstream determinants, you have a huge, what are called best buys.
And I
Yeah.
think
Yeah.
even if I can just jump in, the
please.
individual patient, they go to the cardiologist, the diabetologist, the kidney person. Each of us is talking about a diet. Patient goes home and thinks they have to follow 3 diets. We have to just remind them it's one diet. So even in the individual, this business of simplifying things down to the nuts and bolts, and as you said, the WHO best buys are highly cost effective. And investment today in salt and tobacco and exercise and diet is going to bring great yield in 10, 15 years.
I just wanted to add one more thing in 1 minute. The problem with us is we are individual focused. When we talk about prevention of or management of patients, we tell patients that you have to modify your diet, reduce your carbohydrate intake, increase your fiber intake, increase your protein intake, reduce your salt intake. The problem is, how is this poor individual going to do it when the whole family has a different perception? So you really require family-based intervention, which is a new concept. We published a paper in Lancet a few years back where we showed that family-based interventions can actually reduce or control risk factors 2.5 times better than individual focus. So we need to rethink our approaches.
Absolutely.
Yeah, so really important. Go ahead, Stephen.
It comes back to a point is we have to look at not just the citizen or the patient individually, but he is in the context of social economic situation, and quite often in heart failure. I work in educational therapy, and we do workshops on diet, etc. And interestingly enough, in one place where we have educational therapy, the diet includes all different pathologies. It's not just heart failure. The other thing about heart failure in France, in any case, I don't know if it's across the board, but quite often when we have these sessions on diet, Mr. always comes with Mrs. She's the one that comes. If Madam has heart failure, she comes alone, because quite often it's Madam who cooks, who deals with the medication, etc. It's offloaded to the wife. So you really have to include everybody in the family. I think in things like diabetes, it's shown that if, or not just diabetes, but in obesity, that if it's in the family, then everybody's involved.
Yeah, so really important discussion across our panel. And just like we said, in healthcare delivery, this should be integrated. We don't live in isolation. We live with people we love, within families, within communities, often within the context of the circumstances of the communities in which we live. So I love the 3, 4, 50, simplify, think upstream. The NCDs, the factors that affect them, not surprisingly, have a lot of commonality. And then, not surprisingly, the pathophysiology over time has commonality as well. And so as we address these from a much larger context, we are really preventing many chronic diseases over time. And it's about making the healthy choice the easy choice, because we have to think about social determinants of health, but even better, making the healthy choice the choice we don't have to make, because that choice comes within the foods we're eating anyway. If we reduce salt over time, we don't have to make a choice. We're just eating what we eat. It's just a healthier choice.
I think one thing which we have forgotten, which is the elephant in the room, is air pollution.
Yeah.
In fact, WHO is raised, it had a 4x4 paradigm, now it has a 5x5 paradigm. The 5 areas of intervention that are required are tobacco, diet, physical activity, alcohol, and they've added air pollution to the mix. In fact, we have done a large study in India, a longitudinal study, to show that PM2.5, which is a marker of air pollution, increases blood pressure by 3 to 5 millimeters, both in the short term, medium term, and long term. What it translates at a population level is a 50% excess of hypertension. So if you are going to control air pollution at an upstream level, you can reduce population level blood pressure by 15%. That's the power of addressing social determinants. I just wanted to make that point.
And we know that particle pollution is also not equitable, even within small geographic areas. And this, at least in our nation, but probably many places around the world, where people live is often not by accident. It is either related to historical factors or economic factors, and those that are most disadvantaged are often living under conditions that are putting them at further disadvantage related to chronic diseases.
Yes, thank you. I just wanted to jump in there as well. I think we in the kidney sort of world have also been emphasizing the importance of all the 17 Sustainable Development Goals for kidney health as well as cardiovascular health. And how we sort of came upon this was this also there's this risk of cardiovascular disease and kidney disease that starts in the fetus. So these risks actually are programmed when mothers are not healthy, when babies are born small or preterm, and there's 25 million babies born small and preterm every year, a large amount of them in India. And these babies then grow up, and especially if they gain weight over their lifetime, they have premature heart disease, premature hypertension, premature diabetes, premature kidney disease. So all the sustainable development goals and social determinants of health, and even structural determinants and structural violence like discrimination, are enormous contributors. And you were mentioning pollution. There's a lot of evidence there as well that causes directly cardiovascular inflammation, kidney disease, proteinuria, etc. So, you know, we need a healthy planet for healthy people, and that's again where the policymakers come in. But it has to be multi-sectoral, and one can't do it in the silo of healthcare. We need the economists, the environmentalists, the finance people, the infrastructure people.
Well, thanks to the WHF, we're here talking amongst each other. We're also listening. We are creating common themes. But let's come back to Stephen, because health and well-being it's about communication, it's about listening. And so what advice can you give us, members of the healthcare team, and that means broadly, and we might be talking about clinicians, public health, public policy. What should we be more aware of, and why should people be more involved in these decisions?
We, as an association, recently with 3 other associations in Europe, conducted a study on what quality of life means for patients. We didn't ask clinicians, we asked patients. And we asked them also if they felt that it was a subject that was dealt with in their consultations, how often and what level. And the results are actually quite startling. I think we called it in English, heart failure, the unacceptable truth. And when you look at the statistics or the percentages, what heart failure patients, and perhaps you could spread that to most people with chronic disease, are interested in, is not it's something that's kind of diametrically opposite clinicians' view. Clinicians, basically, all your life, you work to prolong life and save it as much as possible. A lot of heart failure patients have actually turned around and said, I don't want to live 3 years longer. What I want is quality of life now. What can you do to change my symptoms? What are you doing to, for example, with beta blockers, they have an adverse effect on my romantic sex life. What can we do to get around that? That's more important to me, is to live as ordinary a life as possible. And I think that quite often, we were talking earlier about looking at the patient. Quite often patients get the idea that they walk into a consultation, basically the healthcare professional is looking at them not as a person, but as a disease. And the guy said, well, there's more to me than that, you know. So I think a better communication across the board. I'm an advocate of educational therapy. In France, it's it's quite well advanced, but the problem is there's no money to finance it and to get people to come to go back into a hospital situation and learn about their disease. Disease management is important, as is prevention, secondary prevention as well. So
talking, listening, and we talk about goals of care, and you mentioned how, your goals of care may be completely different from the clinician or clinical team. So how do we synergize those goals of care? And I'll come back to the partnered care, and you get more votes because they're the goals of your care, not my goals of your care for you. So we'll have 2 more questions, then we're going to open things up to our attendees here. So be thinking about some questions or comments about how you want to engage our expert panel or add to the discussion today. So we'll come back to Helen, and we've talked about awareness, we've talked about intersections of disease states and the possibilities of prevention, but we can be aware, but we also have to diagnose early. How can we think about earlier diagnosis and some of the work you've done and your colleagues to better understand the real world opportunities we have to do this?
Yeah, thank you for the question. And I think we're talking about evidence generation, maybe not necessarily the kind of evidence that would be generated in support of getting a new agent approved, not regulatory kind of approval, but more at the clinical practice level. So what does the data tell us about the state of diagnosis right now, for example? And my colleagues and I at AstraZeneca, we launched an initiative called Reveal CKD. You may have seen some of the publications. It's very simple in its conception. Essentially, we have data now from over 500,000 patients in 9 or 10 countries across the world. Brazil, US, Italy, Germany. We're about to go into China. And what we find is we go looking essentially for the extent of diagnosis, or rather the extent of underdiagnosis. And if you go into an electronic medical record and look for laboratory values that would be consistent with a diagnosis, so look, for a GFR measurement or evidence of protein in the urine, see if those lab values are there, and then see if it's coded diagnostically to CKD. If you do that analysis routinely, what we've seen time and time and time again is that CKD stage 3 we were looking for is routinely underdiagnosed. The majority of patients in every country that we've looked at so far are underdiagnosed, and in some countries, Brazil is a really good example, over 90% of patients don't have a diagnosis. It's striking. And I'm a big proponent of data, because I think to try and solve a problem, you have to be able to quantify it. And I think that's the power of data. And I think, we're generating these data as we go along, but I think now it's on all of us. What can we do with the data? We need to get these data into the hands of the policymakers, into the hands of the HCPs. That's how we start to shine a light, I think, on the extent of the problem, and then we can hopefully work together to act and to make a change. We've been looking at the underdiagnosis. We've also been doing some projections to the future, some modeling work, if you like, to look at what happens if we don't act. And not surprisingly, it just gets worse. Okay, so kidney function will continue to decline over the next 5 to 10 years. We will see rates of dialysis go up. We will see transplants go up. We will see, again, this is super interesting, and we've touched on it already, but environmentally, we will see carbon emissions go up, because as patients progress and they get admitted to hospital or they need dialysis, then that in itself is a huge burden on the environment. So you start to put all of this together, and it's a huge impetus now to act. I'm going to come back to the policy piece again, but I think we almost need to find a hook. What will make a difference? What will people remember such that they'll start to act? Maybe it's the environment, right? But we have to think about how can we use the data in our hands to really cause a change here.
Yeah, I think the health systems opportunities to affect our environments are also underappreciated. I know in the U.S., it's a little less than 1 out of every 11 American adults work in the sector of health care and health systems, but the effect of health systems on the environment, both within the system, but the system interfacing with the community, is also greatly underappreciated. So our last question comes back to Prabha, and you've already talked about this, a lot of your leadership related to health systems, the challenge of prevention, detection, management of NCDs, but harnessing this at a systems level and realizing if we don't include primary care, we really, we can be kidney specialists, heart specialists, endocrinologists, policy specialists, but most care is through primary care delivery. So how do we do this better?
Right. I think what we need to do is we need to reimagine the health system. We need to just step back, go to our drawing board and think, because you mentioned climate change, you mentioned the contribution of health system to the environment. In fact, in the US, it's estimated that 5% of the greenhouse gases come from the health system. And they're very simple things which can be tackled. Energy consumption, supply chain issues, waste management, 3 simple issues which can be managed. So that is not in our conscious. That's beside the point. So we need to make the primary care not only climate resilient, environment friendly, but at the same time empathetic and catering to the needs of the patients. So the first thing is we need simplification for doctors. It's very complex. You have to fill in so many forms. We have to do so many things. Can we have a kind of team-based care, which you have been talking about, where you have physician assistants or others who are helping so that there is adequate time for the doctor to spend with the patient at the level of the primary care. Second thing is guidelines need to be simplified. We have 100 pages of guidelines. Nobody reads it. How do we actually filter what is really required and give it to the doctor? Third is technology. I think we should harness frugal technologies, which actually saves time. So the nurse or the primary care or the community health worker can input patient data. And we have been doing that so that it saves a lot of time for the doctor. The doctor just needs to look at and create decision support systems for many of these diseases, which gives electronic advice to the doctor in terms of the diagnosis, in terms of the treatment, and errors of omission, errors of commission are actually reduced. In fact, the US system, it's estimated that, what is it called, the harms of, I've forgotten the terminology, that deaths due to accidental interventions or improper care is pretty high. I'm forgetting the...
Iatrogenic.
Iatrogenic, yeah. Iatrogenic, that's pretty high. So those can be overcome by these digital solutions. And there are several digital solutions that are available now. In fact, many people have started working on interoperable systems. Earlier, the biggest barrier was interoperability, but now there are systems that are available that are interoperable. So there are lots of things that can be done. The third thing that we need to think about is the care of multiple long-term conditions, not thinking in terms of silos. We will deal with cardiology, we will deal with kidney disease, we'll deal with diabetes one at a time. But going beyond this metabolic disease clusters, there are other diseases that impact. For example, somebody with diabetes can have depression, and that could prevent adequate care of that patient. So how do we co-manage that? Somebody with osteoarthritis may not be able to do physical activity. How do you manage that? So those are the kind of things which we need to think of in terms of multiple long-term conditions. And the last thing is, we should always engage with the community to find out what exactly that they want. So some decentralization at the level of the community. There has to be a centralization in terms of prevention, but in the terms of management, there needs to be some decentralization where there's a dialogue with the community.
Wonderful. So we definitely want to thank our panelists for their words of wisdom. We're going to open our discussion up to our attendees here at ESC in Amsterdam. We're at the WHF Café, and Sean is ready to increase his step count of the day with a roving mic. And so please don't be shy. We'd love to hear your questions, and if you want to, share your name. If you want to make this a general question to the panel, please say so. But if you have a specific question for one of our panelists, please indicate that. So don't be shy. We'd love to hear from you because here we're speaking at the panel, but each and every one of you contributes significantly to the conversation.
Hello, I'm Brian Kennedy. I'm here on behalf of the Global Alliance for Patient Access. And I'm curious what you see as the number one barrier to patients being screened for these conditions.
So the question is about barriers and what's number one? And we've talked about the challenges, but what's the number one barrier? And so maybe I think many of our panelists could answer this from their perspective. Maybe Helen, to start out with you and hear from our other two global experts.
I'm going for awareness coupled with kind of policy. Yeah.
Great. And do you have a thought, Valerie, about
I think
number one barrier?
I think as well, in the US, they had a campaign that people should, we know 1 in 10 people has some form of kidney disease. People should be empowered to ask their doctors, what is my number? What is my kidney function number? What is my urine protein number?
And Prabha, do you have a thought, just if you
So
pick the number one barrier?
So I think I should confine to a few words like both of you did. Awareness, availability, distribution, and of course access. The last thing is context. Just to give you an example, in a village in India, if somebody wants to get a screening done, it takes 1 full day. They have to go to a primary healthcare center, which is just 30 miles away. But it'll take 1 full day because they have to get a public transport, go there, get it done, come back, then get a report. So we need to think of point-of-care devices, where you can go to their houses and get the test done.
It's an interesting point because an Italian cardiologist, I don't know if he's here, they've actually experimented taking the devices out to people in their home to do ultrasounds for the heart and everything. And there's a lot of talk at the moment saying we have to decentralize the hospital. In actual fact, take the hospital out with its own walls towards the community, because the hospital could be anywhere.
Yeah, so transportation, access. For some people, public transportation is 1 foot at a time, right? In many places around the world, people walk those 30 miles or more to get access to care. Other comments or questions from members of the audience? We're keeping an eye out for you here. In the back, please.
Good morning. I'm Paul McGreevy from the ESC Patient Forum. I'm interested in the discussion that's going on at the moment in terms of working with patients. So my question is, how as medical professionals, not everyone on the panel is a medical professional, but how as medical professionals do you think we should educate and empower patients rather than working specifically with clinicians and other medical professionals?
So how do we collectively help with that empowerment, make voices heard, heard locally, maybe heard at a community level, but even stronger, heard at a policy level. So maybe we'll go down the line here, and just to be attuned to time, then we're going to ask each of our experts to succinctly give their final comments. So we'll go down the line. Keep your answers, short, but we do want to hear about this.
I think patients can actually empower each other. And I think patient support groups or patient education is probably more powerful, because people know the questions that they're dealing with at home, what the disease does to impact their quality of life. So I really feel that, again, partnering, but I feel there's some incredibly well-informed, empowered patients, and I believe they need to be leaders of these strategies.
Stephen?
Like Dave said, let patients help in his book. But we know each other, and we both belong to umbrella organizations for patients, and that's where we get our strength from, working with those organizations and also being integrated into organizations such as the Heart Failure Policy Network, where we literally are going out to the European Parliament and saying, this is what we want. When do we want it? Now.
So opportunities for that voice.
Yep.
Prabha?
Right, I think both of them said. So when we think about behavior change communication, I think we need to look at three things. We need to provide information and education so that the person says, I know, that they've gained the knowledge. The second thing is we should make them, we should empower them so that they say, I can. And the third thing in terms of education is we should make them advocates so that they say, I want, and go and demand. And the last thing that each one has to teach one is what you said, so that they become networks. So for all this, you require an enabling environment. So it's a mix of all of these.
Wonderful. And then Helen?
I think we got it. We're all saying the same thing. It's about empowering the patients, giving them the information that they can then go and advocate, know your numbers, be able to work together, build a mass, a critical mass. I think that's what it's all about.
All right. So as we're coming to a close, I'm going to ask each of our panelists on behalf of WHF to provide a final comment succinctly. Importantly, we're going to leave Stephen with the final comment because it is having that voice and communication and listening. So, Helen, comment.
Sure, thank you. Well, first of all, thank you. This has been a wonderful exchange. I very much appreciate being part of it. For me, the common theme here is connection. So it's appreciating the connection between the heart and the kidney, the disease states, but it's the connection of all of us working together across the care pathway to make sure that we can get that early diagnosis. You know, a late diagnosis is a missed opportunity. Get the diagnosis, allow the patients to benefit and live longer, healthier lives.
Excellent. Prabha.
So we have spoken a lot. So at 30,000 feet level, I want to say a few things. And this might sound cliched and repetitive, but I just want to say this again. So normally I say that there are 3 E's that are required. We need an empowered community, empowered patient, etc. We need energetic profession like the societies and others who can influence change. We require enlightened polity because the policymakers should be listening. But because you're sitting here, I added another E. We require an empathetic industry.
Yep.
All right. Valerie?
Thank you. Yes, so again, protecting kidneys protects hearts. We're here at the World Heart Federation Café. But just to follow up on a couple of tiny points, if we do nothing, kidney disease is projected to become the 5th global leading cause of years of life lost by 2040. Again, if we do nothing and people present at late stages, the treatment of people with late stages of disease causes a lot more health emissions and climate change than if we do prevention and early. And now we have game-changing medications. We know that they work. So we need to actually implement them. We need to get them into practice, and we need to educate the public, the policymakers, and the care providers so that we can all reach the common goal of healthy kidneys, healthy hearts, and good quality life.
All right, Stephen.
Really happy to hear educate everybody else and not mention particularly the patient, because we tend to look at the patient as somebody that needs to be educated. First of all, can I thank Sean and the World Heart Foundation for this opportunity, and that just goes to show that we can be involved more in events like this, even though there are limitations, which we won't go into. But it's a first step, and I really think, you know, that's the way to go, communicating, listening, and considering patients as part of this process. We're not in the periphery. We talked about patient-centered care. That's fine. But I've got a series of slides that when I present patient advocacy, the natural fact, the patient isn't the car in the car wash with all these services round about him. The patient really has to be outside, around the table as a major stakeholder in policy decisions, healthcare policy decisions.
So on behalf of WHF, I want to thank our support from AstraZeneca, number one, our truly outstanding panelists for this vibrant but critically important discussion about the intersection between CKD and cardiovascular health. And so I'm just going to summarize. My take-homes are all about connection, empowerment for change, protect and prevent. Inaction is unacceptable. And Stephen left us with the power of communication and listening. So we want to thank all of you for being here today at the WHF Café in Amsterdam, ESC 2023. So thank you all.
Thank you.